You got it?
Yeah.
Perfect. Hey everybody in Facebook and Instagram world, we're live on both platforms here this afternoon, not morning.
It's been a
So
long
we're
day.
here, it's been a long day. We're here with Dr. Pisano and Dr. Nastella right now. Dr. Garza's on his way, and then Dr. Arisha and Dr. Crisopolo are hopefully going to be able to join in live with us in just a few minutes. So, in the meantime, we do a little introduction of you guys. I'm going to start with Dr. Pisano.
Hello, Steve Pisano, PRMA San Antonio. This is our 27th year in practice. I think we started in 1994, and we have 8 physicians in the group. We're looking at hiring a 9th, which just puts a point on the growth of our practice, the way we've been able to expand our reach in our community here in San Antonio, but far beyond now, really throughout the country. People come from all over the country for reconstruction. So it's just an amazing time in our practice. It's a busy time, especially now that this is Breast Cancer Awareness Month. But we're revved up and the practice is in high gear, and it's an important time of year for us. So we embrace that and look forward to seeing that through to the end of the year.
Yesterday was an exciting day for PRMA. You and Dr. Crisopolo did number 10,000 flap for PRMA yesterday. Crystal and I got to go see her in the hospital today. She was up walking around and she was doing really good walking those halls.
Yes, and historic day for the practice, 10,000 flaps. And I made the comment yesterday that in our practice, we keep track of our case numbers. It's a way for us to follow our progress over both short and long periods of time. But we remember and we respect the fact that behind that number are people, are patients who are mothers and daughters and professionals and people who have families and are confronted with the diagnosis of breast cancer or the threat of getting breast cancer with a genetic syndrome. So we're quick to say we're proud of that number, but we're quick to add that those are lives, those are people that we're responsible for, and it's an honor and a privilege to be a part of that, to have that reach.
Let's introduce Dr. Nastella over here.
Hi, Chet Nastella. I've been with the practice coming on my 20th year now, which is amazing if you think about it. 20 years with such a great group. I knew Dr. Pisano and Dr. Ledoux when I was a junior faculty over at the University of Texas Health Science Center when we first came to Texas. So I was heading up the breast reconstruction program over there. I did a lot of breast reconstruction. We certainly didn't do 10,000, but we did a few hundred. And after about 4 years with the University of Texas, I joined the group to form 3 of us, and now there are 8. So we've come a long way. I spent 10 years before that in Pittsburgh, at the University of Pittsburgh Medical Center, learning how to do microsurgery and breast reconstruction surgery. So this is about 31, 32 years for me, which is kind of getting up there. But it's still exciting. Every day is we're passionate about it. We love our patients. We do love microsurgery too, for its ability to restore form and function to the body in a way that implants can't. And that's why I joined the practice, and that's how we've grown it. So I think until there's the next great discovery, when we can grow tissue in the lab and actually use it outside of just the laboratory, this is the best thing we can get to restoring what plastic surgery is all about. I went into plastic surgery just because of its the great breadth of surgery that you can do, and the fact that it's reconstructive, not destructive. So it's just a fascinating field, and we We love the teamwork of what we do, both in the OR as well as in the office and in our patients who come now from not only San Antonio, Texas, but from all over to allow us to take care of them. So Broad Day is really important to us. We know that it was started a few years back. I think it was Canada, is that right?
Yeah,
It
Canada.
started in Canada, just to raise awareness for breast reconstruction as an option, because despite the incredible advances in medical care across the board, many patients weren't offered reconstruction, so it seemed like a little bit of a discontinuity there.
I'm hearing Canada's kind of still there. I actually have a lady from Canada right now who I'm talking to, and she's saying that she's not being given any autologous reconstruction options at all.
Oh, my goodness.
So she's actually looking at traveling down here for that option.
Yeah.
Which is surprising.
We're privileged to be able to offer what we do, and this is something that requires a team. It's not a surgery that is a quick fix in an outpatient center, but we're getting more and more towards outpatient surgery, at least for our reconstructive secondary procedures. So happy to speak today.
And I know that's something, Dr. Bizzano, you were talking about the other day. You had a patient recently who had a pretty short stay after her DIEP flap.
Yeah, in the history of doing that procedure, the hospital stay has gone from 7 days, sometimes more than 7 days, down to 2, and now really we're looking at having it be an overnight stay. So with the proper patient selection, we can get patients out the day after surgery. It's not for every patient, but
Yeah.
With the proper preparation, it can be done. And that's made these tissue reconstructions that Dr. Nastella was talking about much more accessible, much more doable, and not so daunting a process in terms of an undertaking and the time off work and the time for recovery. And that's been an important change in our lifetime of doing this kind of a procedure. Is
Mm-hmm.
It's been a big change.
the shortening of the hospital stay.
We were just talking the other day in the OR on September 11th, a day that all of us just really feel a lot of emotion for. And I remember on September 11th, 2001, I was watching the unfolding of things in the ICU on my DIEP flap patients, but in those days they were pre-tram patients, and I was at the university right before I joined PRMA, and that's over 20 years ago.
Yeah.
We'll just had the 20th anniversary, and our patients would stay in the ICU often 1 or 2 days.
Mm-hmm.
The reason they stayed in the ICU was it was thought to be a very big procedure, and we had to worry about bleeding, and we kept patients on anticoagulants, and we kept patients on sometimes dextran, things that would expand their plasma. So they received a lot of fluid back then. They had to go in the ICU. They received anticoagulation. You had to monitor that. Now, fast forward 20 years and talk about all the different interventions and all the advancements made year by year by year. Now we have an ERAS protocol where afterwards there's no anticoagulation other than baby aspirin, and while you're in the hospital, a derivative of heparin, which is given as a sub-Q injection. So there's not a lot of that things that will keep you in the ICU.
That's awesome. We're having a couple of people who are saying maybe they're having a little bit hard time hearing.
Oh.
I'll try and scoot up a little bit
Step a little.
in a minute,
Scoot it
but
a little bit. Yeah.
so let me get into a couple questions that we're having come in. Obviously, if you guys have any questions about reconstruction or anything you just want me to ask them for you, you can go ahead and leave them in the comments here on the videos, either Instagram or Facebook, and I'll ask for you. Dr. Garza, like I said, should be here shortly. He was coming from the hospital. He was in surgery today, so we'll grab him in a little bit. But just a couple questions about the practice for starters. So obviously one of the questions was, how many breast reconstruction procedures have we performed? I think that's pretty obvious now.
Yeah.
Just hit number 10,000 yesterday, so and we're going every day. So what about residents or fellows? Do we have any of those here in the practice?
I can take that. We're not a teaching practice on a routine basis. We don't have residents or fellows routinely. However, on occasion, more so fellows, maybe from other programs and other places, may contact us because they're aware that we have a high volume for tissue reconstruction and will ask to come spend some time with us. We're happy to have people come and observe. We don't turn people away who want to do that. In the earlier days of the practice, we were affiliated with the university and we had residents rotate through, but we don't do that routinely now. But we're happy to do it. We're all sort of teachers by nature. As Dr. Nastala explained, he started his career in an academic setting. I didn't mention in my sort of introductory bio, I did my fellowship at MD Anderson. I was a junior faculty associate there, and that's obviously one of the world's great teaching centers. So we all have a teaching background and are happy to do it. Just to complete the point, it's not a routine part of our practice, in my view, because the volume is so high that we're just kind of in the trenches, and we have physician assistants who help us in the OR. And just as a matter of streamlining, some years ago, we just made the decision that we weren't going to have that be a routine part of the practice. We do the cases as a team together. Dr. Nastala, I helped Dr. Nastala today, as a matter of fact, earlier today. So, as opposed to having an attending physician and a resident, or an attending physician and a fellow, it's the PRMA physicians working together as a team.
That's awesome. It's the kind of the good thing about having it takes a village. There you go.
Yeah.
Everybody works together really well, and
Yeah.
I love seeing that here. One of the questions, Dr. Nastala, is how long does a deep surgery take?
It's a good question. There's a bit of variability in it. It's not, we can't say it's exactly 3 hours or 4 hours, but it's somewhere about 3 to 4 hours per side. Hello, person.
Hey, there he is.
We finished today's surgery at 1 o'clock.
Much faster
1
than that today.
It was
It's really
it was a thinner patient, and the anatomy was good. We like to streamline it to make it as easy as possible on the patient, but also we're trying to get the best result possible, so we take our time when it's needed to take our time.
Yeah.
But in general, most of deep flap surgeries that are bilateral finish by about 3 o'clock.
Okay. Dr. Garza just got here. He just came from surgery, right?
Yes, we are at this thing.
If you want to say hi, introduce yourself, tell us. They already told us all about them.
Okay. Sorry, I'm late. So I'm Ramon Garza, one of the PRMA plastic surgeons here in San Antonio. Just like the rest of the team, we all do microsurgery. We do breast reconstruction as a primary focus of our practice, and I also do lymphedema surgery. So that's one thing that I'm passionate about and like to help patients.
In lymphedema surgery, that's something standalone, as a standalone procedure, obviously.
Right.
But is sometimes an option for people who are having deep flap.
Correct. Yes, we. If someone's had a mastectomy and has undergone treatment for their breast cancer, and in doing so has developed lymphedema, and they are wanting to have breast reconstruction, we can include a lymph node transfer at the time of reconstruction to help with their lymphedema symptoms. That's a very good way to manage lymphedema. Unfortunately, there is no cure for lymphedema, but we can treat it and improve symptoms, and best of all, prevent progression of disease.
One of our vendors today, one of the people we spotlighted today too, was Rachel Larson, who is over at Forte. Obviously, she does a lot for people with lymphedema as well. So if there is anyone out there in Facebook or Instagram world that has questions about lymphedema, that is somewhere to reach out to, is Forte, as well as here Dr. Garza can chat with you and tell you your options as well. One of the questions we have on here is asking about feeling after mastectomies. So somebody asked if their reconstructed breasts will have any feeling. Dr. Pisano, you want to take that?
I can That's a great question and a complicated question, and it's probably going to take all three of us to answer it. So the immediate answer, the short answer is yes. There may be sensation to the reconstructed breast. It depends on many things. It depends on whether the reconstruction is an immediate reconstruction versus a delayed reconstruction, meaning the reconstruction is done at the time of the mastectomy versus the mastectomy is done and then the reconstruction is done later, in other words, delayed. So it's helpful to have it done as an immediate if that's possible, because then the envelope of skin that covers the breast is preserved. And furthermore, in this day and age, many mastectomies can be done in a way that preserves the nipple and the areola, and that helps with overall sensation. So the first part of the answer is how the mastectomy is done. So to summarize, immediate versus delayed, and nipple sparing versus skin sparing or non-nipple sparing. The second part of that has to do with bringing sensation to the flap. So I'm going to turn that over to Dr. Nastella, otherwise I'm going to be talking about
Okay,
it
there you
forever.
go. So, in order to achieve sensation in a reconstructed body part, you have to have a nerve available as what we call a donor nerve, and then you have a nerve as a recipient nerve. And those two nerves can be brought together, what we call an anastomosis or a neuropathy, microneuropathy. Those could be sewn together. The nerve, once they're joined, it's not like electricity where it'll be flowing immediately. It takes about an inch a month or so for the nerves to regenerate through the tube of the recipient side. So if you view the breast three-dimensionally and it has 4 to 5 to 6 inches from the chest wall, it'll take 6 months or so for some sensation to return. Now, the degree of sensory return is variable in everybody. We have some patients who have sensation and then to get back, because that typically involves a complex set of nerves. So you're looking at more temperature to be protected, and then sensation to touch so that the body feels normal. And more importantly too, so that you don't have abnormal sensations, which are called in medical terms dysesthesias or hyposthesias, which means you can have pain that's abnormal when a body part is touched. So we want to avoid that. So it's just as important to avoid bad sensations, such as happens in a mastectomy without reconstruction, if the chest wall nerves are being bound up in skin and scar. So it's a complex topic.
I want to add a little bit to what Dr. Nastella was saying about the dysesthesias. Sometimes when our patients have had, particularly that have had axillary lymph node dissections, and I'll often see these patients when they have their lymphedema issues, but they can have dysesthesias in the area, especially on the lateral aspect of their breast, on the outside aspect of their breast, where they have these painful areas that are sensitive to touch, oftentimes numbness. If you've gone to the dentist and had your mouth numbed up, your lips feel very large. They feel abnormally large, and even though they're not particularly swollen. Well, the same thing can happen in the area where surgery is done. If those nerves are affected, patients can have these unusual symptoms and feel like they have puffiness out in the lateral aspect of their breast or along their chest wall. And one of the approaches that we can use to help with those symptoms is using our physical therapy resources. The therapists are very good at helping retrain the nerves in those areas to prevent from sending those abnormal responses to the brain and the way our brain interprets that, so they can help with patients that are having symptoms such as the dysesthesias.
Can I make another comment on that too? I think one of the aspects of the practice that we try to promote in broad day is important, the awareness of breast reconstruction. I think we all are very sensitive to the need to make sure that nerve connections are done properly, and when we can do it. That's not necessarily across the country in a lot of practices, but both plastic surgery and general surgery practices. For example, when axillary dissections are done, oftentimes the intercostal brachial nerves are cut, and it gives you numbness in the under part of the arm. So if we're doing reconstruction at the same time and we either notice that or we're able to find that by the microscope or the loop magnification, we can then repair those nerves properly. A person who may be getting an axillary dissection without reconstruction may not be recognized as those nerves.
We did that just yesterday. The
Mhm.
very thing you're talking about, we saw
Mhm.
the sensory nerve that Dr. Nostal is talking about that goes from the chest to the arm had been cut because the general surgeon had to do a full axillary dissection, meaning taking out all the readily available
Mhm.
lymph nodes in the underarm. And we saw that nerve was cut and we were able to repair it. So
The other thing that we've been doing is working closely with the general surgeons and the oncologic surgeons to identify and isolate the nerves that go into the breast specimen and tag those so they can then be repaired later. I've even had patients who've had delayed reconstruction that their general surgeons contacted us and said, what do I do about this nerve? I said, just tag it or mark it, or we talked about that, and so that the nerve reconstruction can be done later. So even in a delayed reconstruction, sensation can be attempted to be achieved.
If they've had deep flap sensation return, is it normal to experience random shooting pains? Is that normal?
yes,
Yeah.
I'm just going to jump on that. That's a very common, especially when you are several months after surgery, sort of recalling something Dr. Nostala just mentioned. As that nerve starts to grow, you get several months out from the nerve repair. We say the tissues are waking up. As that nerve is growing and bringing sensation to an ever greater area of the chest wall skin or the flap itself, there's a period of time, it's 6 weeks, 8 weeks, out to several months, 3 months, where that happens. It generally quiets down. It's temporary in most patients that we're talking about in this setting, doing these nerve repairs in the setting of a tissue reconstruction. It's overwhelmingly, in the majority of patients, temporary.
If someone's not a candidate for deep flap but wants to have nerve reconstruction, do they have any options? Is there any options for that?
Yes, this whole topic of sensation to the breast or the reconstructed breast is a frontier now in reconstructive surgery. And one of the things that can be done is reconnecting nerves, even in the setting of an implant reconstruction, if you can find the nerve end on the undersurface of the pocket that's left after the mastectomy is done, underneath the envelope of skin that covers the breast, and reconnecting that nerve to, again, what Dr. Nostala was just talking about, a nerve that's been cut during the mastectomy in the chest wall. So bringing sensation to the native breast skin. Can that be done? Yes, it can be done. It's tough. The nerves are small. You've got to find them under the microscope. But yes, that's the frontier now, is restoring sensation, especially around the nipple and the areola. That would be the state of the art. Absolutely.
Maybe Dr. Crisopolo can comment, because I know he's done some nerve reconstructions on implant cases. It's more difficult to do, but
yeah.
Okay. Well, he said he was going to try and join here on Instagram, so we'll see if he pops in there.
And I want to add one more
Okay.
thing, because I'm looking, the audience can't see it. But
My beautiful sign? Is that what you're referring to?
So we're so passionate about this idea of sensation to the native breast skin and the reconstructed breast that the practice has coined a term, if you will, called TrueSense. So we've given a name, a proprietary name, to this whole process, because we want people to know, we want our patients to know that this is at the forefront of our breast reconstruction. And when you name something or you label something, it means you're in it. You've called it something. And so we had a specialist who comes up with give it the name TrueSense. So That's how strongly we feel about it.
I like it. I think it's a great name.
So we often get this question, patients that have had DIEP flaps previously before seeing us, they do ask if they'll ever get the option to have that sense of, again, like the nerve sense. Is that in true sense an option for them after
That's
having
a
a
great
DIEP flap?
question. What do you gentlemen think about that?
You know, coming back after you've had initial surgery and had reconstruction, I think it's a very challenging thing. Not that it couldn't be done. We haven't. I don't know if it's been done before in the practice. I have not had the experience of doing that.
I haven't done
With harvesting the flap initially, it's very important, and you know, like Dr. Bazan and Dr. Sala were saying, that we try to do this for all of our patients. That's how passionate we are about it. When you're doing the flap dissection, you have to include the nerve in that initial dissection. Once that nerve's been transected, if you know you go to a surgeon who isn't as careful with doing the flap dissection, doesn't include that nerve, you kind of miss the opportunity, I think, to find that nerve and do the connection. It would be very challenging to go back at a separate time after the initial surgery to try to find a nerve stump at that point and do a nerve connection. You know, who knows, in medicine, if things change and we find new ways to do things, there may be an opportunity to find nerves or regenerate nerves to improve sensation in those areas, but I think right now that'd be very difficult to do, if not impossible.
I know. I think I'd have to echo that. When it's like building a house and you put the wiring in the walls when you're building it, and to go back, you can do it, but it's very difficult.
What about radiation? Does that impact the success of sensory nerve reconstruction?
Good question. I think in radiation, just like in sensation, there are various degrees of damage done by radiation. The best thing we can do for radiation is work closely with the radiation oncologist to make sure that patients get the best results possible. Just the lady who did today had radiation, but had fantastic work for months and months with the physical therapists, with everybody working on the patient to really make the radiation damage less. So therefore the nerves are intact, you can do the primary repairs. Now, many patients who've had radiation years ago have had a lot of cumulative damage. It may be difficult to find those nerve stumps when we do the reconstruction.
Yeah.
That's very variable, and so we're so concerned. That's another forefront of medicine, especially in breast reconstruction. So even just a few weeks ago, we had meetings with our radiation oncologists to work on new parameters to minimize radiation damage, to get the best results, so that we can make sure that patients can get good sensory return even after radiation. It's a team effort in that regard.
In talking about radiation, what type of reconstruction is recommended when radiation is planned?
Let me take that to, well, I think all three of us will need to weigh in on that. In our practice, we have a philosophy that in the setting of radiation, autologous tissue is the best type of reconstruction to perform. And the reason for that is the success rate with the tissue reconstruction in the setting of radiation is very, very high. In our practice, especially for the DIEP flap, the DIEP flap, the success rate is at or better than 99%. The success rate with an implant-based reconstruction in the setting of radiation is far lower. It may be 60%, 70%, and that's probably at best. I'm going to turn that statistic around. The failure rate for an implant-based reconstruction in the setting of radiation is, the failure rate's 30%, 40%, and can be higher. So our philosophy, and this is a long-standing philosophy going back to the beginning of the practice when, as a group, we decided to make tissue reconstruction the core service of the practice. So in our collective opinion in the group, tissue reconstruction is the state of the art. That's the way to go. And I'll add, as a a transition to let my colleagues weigh in on this very important topic that we, as Dr. Nastala said, are currently in this kind of forefront where we're working with the radiation oncologists to see, are there ways to do immediate reconstruction and reliably then do radiation so it doesn't hurt the flap? Or are there ways to have a patient have a lumpectomy as a temporary measure, get radiated, and then come back and do the completion mastectomy and reconstruction? So this whole issue of how radiation impacts reconstruction is very, very complex. So I'm going to turn this over to my colleagues because there's so much more to say, and I know I'll leave something out, and let them add what they will.
Yeah, so Dr. Pisano was, I think, generous in that success rate. And one thing you have to point out is how do you define success? With an implant that's being radiated, that's not. Sometimes, if you look at the studies, sometimes they'll define success in some of these studies. 5 year of no complications. Well, most of our patients have a lot of time left with the implant reconstruction, and defining a success is only having the implant in for 5 years without an issue. In our mind, is not a true success if the implant has to come out at year 6, or the patient has to have revision surgery to address complications from the radiated implant, such as capsular contracture at year 6 or 7. In my mind, that's not a success. What we deem as success is a long-standing reconstruction that is complication-free and is going to be a good cosmetic outcome. So in my mind, a lot of times doing an implant with radiation is not going to be successful, period. Even, in the long term, is definitely not going to be, in most cases, it's not going to be successful.
Timing wise for breast reconstruction after radiation, what does that look like?
For flap reconstruction, we've shortened the time frame that we've agreed to wait. Previously, many years ago, it used to be a year, and then we've brought it down to 6 months, and now we do it as early as 3 months. It's possible to do it even sooner than that, but with practical considerations and other issues, it's usually not less than 3 months.
Let's see. I had a question about male breast cancer. If a male breast cancer patient undergoes radiation, what options are available?
In a way, it's very similar to the way we would think about reconstruction for breast cancer in women. And here's what I mean by that. In the removal of a male breast cancer, a mastectomy, if you will, on a male, it can be very disfiguring. So we're looking at building up a depth of soft tissue, nipple reconstruction. So I could envision doing a flap reconstruction on a male with a different end in mind, just restoring the normal contour, the normal thickness, and then having a platform to do a nipple reconstruction, whether or not radiation has been done. So I think the set of steps are the same. It's recreating that three-dimensional form and getting symmetry with the other side. And I think this has been an overlooked aspect of reconstruction that in the male patient, it can be every bit as disfiguring. So I think the sequence of steps would be the same: the initial foundation to get that 3-dimension, and then maybe a second stage revision to contour, get things symmetric with the other side, rebuild a nipple areola complex. Because we certainly in men pay a tremendous amount of attention to the position of the nipple areola complex or the form, say for men who have gynecomastia, or in transgender surgery now. We don't do that in our practice, but that is a frontier. We're talking about frontiers. So I think that's a great question and a great consideration to think about the three-dimensional reconstruction in a male with breast cancer?
I like to kind of branch off of that that thought. We have some patients that come to us seeking opinions about going flat, and if we can contribute to the aesthetic outcome, and a patient is going to have a mastectomy, chooses not to have reconstruction in what we would think of as reconstruction, but wants to have an aesthetic outcome with regards to going flat. And I think one of the misconceptions that patients have when they're having a mastectomy and they choose to not have reconstruction and to go flat is the chest wall and the shape of the chest wall. Our chest wall is a convex structure, and the breasts are generally located on the outer portion of that convex structure. And when a mastectomy is done, the breast in its anatomic position has a teardrop shape and it extends out towards the axilla. When a mastectomy is done and it's removing all of the breast tissue, a lot of patients will have a concave appearance to their chest. So we'll have patients that come to us in a delayed fashion and they say, my breast surgeon has disfigured me. I have an indentation in my chest. I want it to go flat, and I'm not flat. I have this concave appearance that I don't appreciate and I don't like. What can be done? And I have to, explain, the dimension of the chest, that it's a convex structure, and when the mastectomy is done, a proper mastectomy, it can leave an indentation there. And that's not to say that the breast surgeon did not do a good job, but maybe they didn't explain as well, what going flat would mean for that particular patient's anatomy. And touching back to the gynecomastia, just restoring chest wall appearance for a man or a patient that chooses to go flat, some of the same approaches can be used to achieve better cosmesis.
Good answer. And going flat is a challenge in and of itself,
yeah.
and I think it's best done in conjunction with the oncologic surgeon, because as we were just speaking about, Dr. Garza said, breast as a three-dimensional structure is essentially within the subcutaneous tissue, and there's not a lot of tissue between the skin and the breast. The breast gland. That's why the challenge of reconstructive surgery is made more difficult with implants, because getting back to implants, if we put implants under a normal breast, as in cosmetic implants, I explain this to patients all the time, the breast is like under a lens and it looks larger, and you can make it look larger in a variety of ways, more fullness up top or down below. But when you're putting in an implant after a mastectomy, the only thing that covers it is skin of variable thickness, unless you augment underneath it with artificial tissue like alloderm or Flex HD or a muscle. So therefore it's very difficult to get that three-dimensional structure, and Dr. Pisano pointed out the failure rates are very, very high with that type of reconstruction. It can be done, and obviously many surgeons do it quite well. Then when you add in radiation on top of that, radiation is a double-edged sword. It cuts both ways, so it kills cancer cells, but it also kills stem cells. And stem cells are what are present within our normal tissues to repair and to maintain our tissues. So therefore, that's why they degenerate with time, and that's why implants degenerate with time. And what may be a success in year 1 is a failure in year 2 because of contracture and so forth. So getting back to the going flat thing, the breast skin gets thinner and thinner and thinner and thinner as we get out toward the most projecting part of the breast. So oftentimes the general surgeon leaves very thin skin flaps. They may be thicker peripherally, but they're very thin as you get to the center. And so if it's just closed by the general surgeon, you'll often get a saucer type appearance, where that skin will heal directly onto rib or chest wall. And that's where we talked about the painful sensations, because you've got skin on chest wall, and that contributes to something what we call post-mastectomy syndrome of pain. So it's all related, and that's why I think it's important for Broad Day to realize that we're here as a resource. There's so many resources available, and it takes time to understand all these things.
Well, and touching base on the implant reconstruction, something Dr. Garza and we did a video recently talking about implant-based reconstruction and how it's different than a cosmetic procedure. Do you want to go over that analogy really quick that we did with that video?
Yeah, so if the patients who have consulted with me, they'll, this is my classic way to describe it. So if you have, you picture like a bowl of fruit.
And we had a bowl of fruit.
We had a bowl of fruit, right? So you picture a bowl of fruit, and you can see all the contours and outline of the fruit. You put a very thin sheet over it. Well, that's kind of what's happening when you do a reconstruction. You can see every little subtle ripple or change within the implant underneath the tissues. When you have a very thick, heavy down blanket and you cover that same bowl of fruit, all those little contour irregularities are now masked by that thick, blanket. Well, that's what happens with a cosmetic breast augmentation. You have a very thick tissue covering the implant, and it's a lot more forgiving to what is going on underneath the surface. So they're just it's comparing apples to oranges, using the same analogy.
Quite literally.
Yeah, for a cosmetic
and
using cosmetic augmentation versus a reconstruction. And even the success rate, in a 10-year time frame, a complication for a breast augmentation is about 7%. In a breast reconstruction, this is without radiation. In breast reconstruction, the need for revision surgery is about 50%. That's to address capsular contractures, poor outcome cosmetically. So there's very different percentages, as far as success within reconstruction and cosmetic surgery.
Moving over to the recovery after DIEP flap a little bit, can we go over what the recovery looks like for that? Do you want to take that?
Recovery after a DIEP flap. I usually tell patients it's 4 to 6 weeks. Now that said, most patients who I'll say a computer-based job nowadays, a desk job we used to say, can go back at 3 or 4 weeks. It depends too if surgery was preceded by chemotherapy. If the chemotherapy was given up front, the patient may be going into the mastectomy and reconstruction a little bit fatigued from the chemotherapy, so maybe I would say the recovery is a little on the longer side, more 5 or 6 weeks. Now, within that time, the recovery has improved vastly. In much the same way we were talking about the length of hospital stay, we can look at it from the perspective of the overall recovery. And Dr. Nastala earlier in this session mentioned the ERAS protocol, so ERAS. That has to do with a protocol, a collection of things that we do now that have markedly improved recovery, has sped up recovery. And that's allowed for the shorter hospital stays, but it's made the recovery much more comfortable. So it's a combination of medicines, mostly over-the-counter medicines, and minimizing or completely eliminating narcotics. Because we've learned that narcotics are generally not helpful for incisional pain. They slow down the gut, so it makes it harder to resume your diet. They make you groggy, with kind of dulling the pain but not really eliminating it. So the collection of medicines we use now are better, and patients can resume their diet faster. So the difference between recovery from a flap, like a DIEP flap, and an implant reconstruction is really not measurable anymore. It's really pretty much the same. The recovery quality is different, but this idea that somehow an implant reconstruction is markedly faster is just really not true anymore. And I hasten to add the disclaimer, if you will. We all do implant reconstructions. We don't do a lot in the group because, again, the core service is tissue reconstruction. We all do implant reconstructions, so it's not as if we don't do them. But because we do them and because we do flaps, we can all confidently say this distinction between the length of time of recovery is very difficult to even measure anymore. And even if you could, if you said, okay, well, an implant reconstruction is maybe a week faster or 2 weeks, what I tell patients is, in the grand scheme of things, in the grand scheme of your life, we're talking about a snapshot in time, like a week or 2 or even 3 of difference. It's not the defining thing about whether you have an implant-based reconstruction versus a tissue-based reconstruction. So here again, many other things to say. I'll turn it over to my colleagues to add to that.
Yeah, so the enhanced recovery, the ERAS protocol it's fantastic. It's really, when I first joined the group, it was routine for our patients to stay in the hospital for 5 days, and it wasn't ICU care. Thankfully, we have a great nursing staff who we rely on tremendously for our patients who are recovering in the hospital. So we don't have our patients go to the ICU, but they were still in the general floor for 5 days when I initially came. Well, with this new ERAS protocols that we've been utilizing, patient stays 24 to 48 hours. Most of our patients come home within 48 hours. In some select patients, we're able to send them on post-op day 1. But day 1 after surgery, our patients are up and walking around. I tell patients coming into surgery that important to come into surgery like you're going to train for some type of athletic event. You want to be as healthy as you can be. So nutrition is optimized, high protein diets. You don't want to be in a calorie deficit state. You don't want to start any crazy diets, coming into surgery. You want to be walking every day up until surgery or doing some form of physical exercise. So you're optimized to have a quick and easy recovery. That's what we want for all of our patients is 0 complications, easy recovery, and get this, segment in your life over with and back on track.
While I have you, I have a patient on here that said she's consulting with you in December. So I figured I'd ask you this question. She had a lumpectomy in May, just finished her last radiation treatment in end of August, and she's looking to get a mastectomy at the same time as her DIEP flap. Can she do that?
Yeah, absolutely.
Yeah.
Yeah, no issues.
Totally normal.
Yeah, I mean, we'll talk, when I see her, I'll talk more specifics about her specific situation, but yeah, I don't see an issue.
Don't see an issue with having DIEP after radiation. And then another question on here is, how is the belly button addressed in Reconstruction? What do we do about the belly button?
So in the DIEP flap, belly button is right at the top of where the DIEP flap is excised, the tissue that gets transferred up to the chest. So the belly button is, you can turn the belly button is left on the abdominal wall with its blood supply as a stalk or like a little funnel. Then when the upper abdominal wall ligaments are released and it's brought down to the lower incision, we try to cosmetically insert the belly button into a new hole that's made there. So essentially it's in the same spot, but it's transposed through that abdominal skin in a new location. As far as the cosmesis of it, what we try to do is put sutures in to make it look as aesthetic as possible, and try to create a good contour with the belly button. The other thing I think is as important as the belly button is the contour of the abdominal site and the donor site closure, which we've started to pay much more attention to over the last few years in terms of abdominal closure. And one of the things I'll mention is what's called rectus diastasis. Many patients will ask me about that beforehand. Typically in years past, it was not addressed in breast reconstruction because the primary focus is the breast reconstruction. But since we have a team that's operating in 2 sites, and as we're doing the closure, if at all possible, it can be repaired. One reason that it was not repaired in the past was that it was thought to put undue tension on the abdominal closure elsewhere, but we try to balance those issues.
I keep hearing this term and I actually don't even know what it is. Swelly belly. Something I keep hearing a lot about. I don't even know what that is.
Well, there's a host of things that can happen with the donor area after the DIEP flap that are unsightly or things that patients don't like about that operation. And one of the things that's evolved over the years in doing DIEP flap surgery in general, but definitely in our group, and as Dr. Nastella said, something we're really paying a lot of attention to, especially over the last few years, is the appearance of the abdomen. So the swollen belly look or the SpongeBob look, some patients will say, that boxy look, I'll see on breast reconstruction sites the Kendall deformity. All these things are talking about the appearance of the abdomen after the DIEP flap. So one thing that happens is you get a tummy tuck. The DIEP flap is a tummy tuck, but instead of discarding the tissue, we're rebuilding the breast with that tissue. So we bring the skin from the upper abdomen down like a curtain, as you would in a tummy tuck. But if you don't address the separation of the rectus muscles, the diastasis that Dr. Nastala mentioned, and other things, you can end up with kind of this plain looking abdomen, not one that has the nice sort of contour or hourglass figure. So in our closure of the donor site now, we pay a lot of attention to that. We close the diastasis, as Dr. Nastala mentioned. We focus on the umbilicus or the navel to make that look attractive. And we do these other internal sutures. The medical word would be plication, or it would be like sewing a dart on a dress or a blouse or something like that, where we tighten up the outer abdominal areas to bring in that contour and make it more attractive. And one of the reasons why we can spend the time doing this now is because we've done so many flaps and that part has become so much more routine that we can allocate time to closure of the donor site. In the early years of doing the DIEP flap, it was all we could do to do the DIEP flap. So that was our focus.
Move the healthy tissue.
Now, we can allocate a lot of time to shaping the breast at that initial procedure, as well as working on the donor site. So we're very sensitive to that. We know that this is a big concern for patients. So we're working harder, ever harder, to get a more aesthetic closure of the donor area, as if it's a person coming in for a tummy tuck, and spend as much and sometimes more time doing that than the initial shaping of the breast, I would say.
What the abdominal tightness? How long does that typically last?
Yes, there's tight. Okay, the first thing to say is yes, there's tightness after doing the DIEP flap, because again, it's a tummy tuck, and if we do all that internal work, patients will comment that things feel tight, and I'm going to say several months. I think for the overwhelming majority of patients, by 2 or 3 months, that's gone. In the occasional patient, it can kind of linger, that sense of tightness, but the overwhelming majority, it's short-lived.
And that would be similar to a tummy tuck. Patients are up walking the next day, and the subjective feeling of sense of tightness, they may say, patients may say, don't feel very tight at all, and others may have a little more tightness. But they're walking the next day. Even some patients walk the same evening as the surgery.
Yeah, we saw that today.
Yeah, we did.
Yeah, for the tightness, it's also very patient dependent. It depends on our anatomy and how patients carry their weight. You know, we're all very different in our anatomic structure, and if a person carries their weight in their lower tummy and they also have redundant skin in that area, well, they're not going to feel very tight at all. That skin is going to come together very easily, and it's not going to be under any undue tension. Converse to that, if we have a patient who is thinner and we need to design our flaps in a way to maximize the cosmetic result, they may be particularly tight, and they will feel tightness in that area, until that skin stretches and they're able to accommodate that new area in the tummy.
So we're almost done here. I know Dr. Crisopolo and Terry Kuti are going to do an Instagram live in a few minutes, but I have just a couple more questions for you guys.
Sure.
Somebody asked if they need to buy anything special to prepare for surgery. Do they need lift chairs? Do they need binders? Do they need pillows? Those type of things.
Recliner is one of the things that many patients try to either rent, borrow, beg, or steal. Because
Well, I know Rose's house has 2 of them now for recovery.
Having a recliner, you're in the hospital. There's one usually provided for us in the chairs there in the private rooms in the hospital. But That's a good thing to have. Just because when you get in a flat bed, if you don't have a wedge and you're wanting to sit up, then you're manipulating pillows and so forth. So extra pillows, recliner. Oftentimes we talk about different options for it, or may provide, or have vendors give us things to hold the drain tubes, post-operative bras, extras like that at the. But really, I think most things are pretty self-evident.
I hear a lot of people on like Deep Sea Journey, they say they have to have a shower chair. Is that something that's necessary? A shower chair?
I think that is helpful. A
Yeah,
plastic
probably,
chair.
that could be a good,
yeah.
Helpful.
I think it's helpful to have a handheld wand in chair. Not everybody has access to it, but I know there's a lot of ways that can be, if you have access to that, that's helpful.
Yeah.
Just for
Shower chair is probably not
yeah.
a bad idea.
What about sensation in the abdomen after the DIEP flap? How is that? Is that the same?
You'll lose some sensation in the lower kind of middle part, because the very nerves that we were talking about earlier that we hook up to nerves in the chest to bring sensation to the flap, the DIEP flap, those are the nerves that are cut. So it's primarily below the navel, sort of between the navel and the pubic bone. That area is going to be numb, and that's probably going to be permanent. Yeah. But again, I would say the overwhelming majority of patients don't complain about that, or it's not an issue long term.
I think that's all the questions we have coming through. Unless you guys have anything to add, we'll let everyone hop over to Dr. Crisopolo and Deep Sea Journey over on Instagram.
We have a minute for one last
Yeah,
one?
go for it.
I just wanted to mention revision surgery
Oh.
after DIEP flap
We
surgery.
didn't even get there.
There are two ways to look at it. If we can do a perfect job and everything looks great, a patient doesn't need to have a revision, but that's pretty rare. And then the other way is, well, everybody should get a revision to really make it as perfect as possible. We're somewhere in the middle, but most patients plan for an outpatient revision surgery, and that's a whole other topic that we can do on not a broad day, but any day. Really talk about things for revision surgery, from soup to nut, so to speak. We can do liposuction, contouring. We can do fat grafting, scar revisions, reshaping. We try to do as much as we can in the first surgery. Dr. Pisano and I talked about the breast shaping. The more we can shape to start with, put sutures in, spanning sutures, cone the breast, that helps.
How long is that typically after the initial surgery?
3 months. If there's no chemotherapy needed, radiation, other things, but it can be done at any point in the future.
And revisions, are they covered by insurance as well, like the DIEP flap? I know we didn't even get their insurance in
It's
breast
covered.
reconstruction.
It is generally
It'll
covered, but sometimes we have to we have to appeal to the insurance companies and let them know that it's
Why.
reconstructive, why it is, correct.
Okay. You guys have anything else you want to add?
Thanks for joining
Thank
us.
you, thanks for
Thanks,
joining
guys.
us.
Yeah,
Thanks
thanks.
for joining us
Awesome.
abroad today.
Thanks for spending your night with us, guys.
Mhm.
Our pleasure.
All right.
Thank
Have
you.
a good night, everyone.
All right, bye.
There we go.